Welcome to the, hi everybody, my name is Glenn Lipton. I'm Glenn Lipton. I'm one of the orthopedic surgeons at Premier Orthopedics. We welcome you to the Facebook Live show today. I'm a sports medicine surgeon. I do minimally invasive surgery at this surgery center. My organization is Premier Orthopedics. It was started about 20 years ago in the year 2000. The goal when they started the company was that to give the best orthopedic care possible and yet not have patients feel like they're numbers on a clipboard. The goal was to give big city medicine with all the best outcomes in the suburbs. And I'm extremely proud of our organization. Through the current pandemic, we were able to keep all of our offices open and provide emergency orthopedic care to our patients. In addition, many of the partners that I have reached out to our local emergency departments in the hospitals. We extended our services to help decompress those staffs so they could focus their care on helping the members in the community who were afflicted by the COVID-19. We are all in this together, and we'll continue to help and serve our community no matter what happens in the future. One comment, our local staffs are amazing in the hospitals, and we thank them for their wonderful care. Premier has been very active in giving the best personalized care to our patients. And now, after 20 years, our organization has grown to well over 100 physicians, PAs, and nurse practitioners, all giving care to our patients. We work in conjunction with athletic trainers, nurses, medical assistants. We have 28 offices in Delaware County, Chester County, Montgomery County, Philadelphia County, and Newcastle County in northern Delaware. Our physical therapy centers are number about 20. We have 58 physical therapists. In addition to that, we have 4 MRI centers in Havertown, Exton, Westchester, and King of Prussia. In addition, to really round out our ability to take care of the patients in our community, we have urgent care centers in Malvern and Media. My focus today, we're going to talk about some basic conditions of the shoulder, knee. I take care of those areas as well as fractures, and I also do general orthopedics. We'll go ahead and we're going to, if we can put up a graphic of the knee, we're going to show a meniscus tear for you now. We're going to show you that tear, and I'll show it again when we talk about the OR experience. But if you look at the knee, we have the view looking from the front. You can see the kneecap there, and we have the meniscus, and the meniscus has a little line to it. And if you remove the top part of the knee and you were looking down from the top down, you can see meniscus can have a tear in it. Those semilunar shapes on the side of the slide there, you can see a tear that's delineated. Those tears can be anywhere. This particular tear is in the anterior part of the knee, and it can be on the back, it can be in the front, it can be on the sides. So we call it anterior, posterior, and body. Names aren't so important, but I wanted to articulate that it can happen anywhere. And doing minimally invasive surgery, we can just treat these with poke holes in the operating room, and we can do it such that there's minimal, morbidity, meaning minimal downtime, and people are back to work at a quicker pace, and they're doing all of their normal activities quicker. The other thing, just a quick show, and I'll pull these pictures up again later, is the anterior cruciate ligament. I have a slide and a picture that we can put up on the screen. And I'll wait for it to pop up. When you look at the anterior cruciate ligament, those injuries can occur as your knee is trying to resist anterior translation of the tibia. And so sometimes if there's a force from a sports injury or other, that can tear. We also do that minimally invasive. There's all inside techniques, which I typically utilize. We harvest and usually take the tendon from the patient, and then we can go ahead and treat we prepare a tendon, we put it in, we use the patient's own tissues in the vast majority of the cases. And the ACL is also done in a minimally invasive technique, and we do them in the surgery centers that we're affiliated with. Can we put up the picture of the anterior cruciate ligament tear? Here it comes. So this is still the meniscus tear. We'll go to the next slide, please. Okay, I think it's coming up in a moment here. If there's any questions at the moment, I can answer them while they're pulling up that slide. And another, oh, here it comes up now. So if you look at this picture, you can see that the anterior cruciate ligament is the ligament that goes from the bone on the bottom to the bone on the top. The bone on the bottom is called the tibia, and the femur is on the top. And when there is a tear, it can tear through multiple areas of it. And in most cases with the anterior cruciate ligament, when it tears, it's not really a repairable structure, and it has to be replaced. So that's the picture. It's the ligaments from inside the knee, and sometimes there's a ligament behind it. Sometimes it gets torn as well, called the posterior cruciate ligament. And depending on the tearing of the posterior cruciate and anterior cruciate, you reconstruct the entire knee. The other thing that I focus on is on shoulder surgeries, and I do the rotator cuff tears, and we'll have a picture of that for you in a moment. And we go ahead in the rotator cuff pathology. Again, it's minimally invasive treatment. I've done roughly 4,000+ of these in the past several years, as an equal number of knees. And it's all done with small poke holes. It's rare that they ever need to be opened. Looking at the particular picture right here, you can see that the rotator cuff inserts on the shoulder, on the humerus, which is the arm bone. And when it contracts, it lifts your arm up. It also does the rotation. So in those pictures, the rotator cuff, there's a partial thickness tear you can see and a full thickness tear. Partial thickness tears many times can be treated without operative intervention. They can be done with shots, physical therapy, anti-inflammatories, and some full thickness tears can be that as well. Treatments always are based upon the patient's physical demands and the like. And so we always tailor our treatments, and we treat every single patient individually. Okay, let's go to the next. You can take off the slide now if you like, and we'll show that video later. So my goal in today in the Facebook Live presentation is to go ahead and kind of bring you through how it is, the nuts and the bolts of how your surgical experience would be, from admission to discharge in an outpatient setting. And so we're very careful here at this particular surgery center here in King of Prussia. This is the King of Prussia Surgery Center, and every single person and every comes in, they need to get their temperature checked. We all have to wear masks at all times. That's why mine's not coming down. The patients, every single one of them is tested for COVID-19, and so we are very careful in an effort to decrease any spread or transmission of COVID-19. And even that, when they come in, then they get another set of questions they're asked to make sure that we're safe and we don't have any issues with spreading of any kind of disease. After you get your clearance and you come in, you get checked in. We have a wonderful staff here. They check your paperwork, they check your identification, and they strive to make sure that all of that's done ahead of time, so it's a smooth process for you. Next, you go to the pre-op holding area, and what happens preoperatively is your doctors evaluate you in the office, and they see whether or not you are an appropriate candidate for surgery or not. And then they also you'll get a history and physical, and some people need medical clearances, other people are healthy and don't need that. So in the days and weeks before you're preparing for your visit, part of it is going to be getting your labs done if required. Some people have more invasive procedures, and they will need to get a battery of labs. Other people have minor procedures and really don't need that. Your doctor will review your chart. The allergies will be reviewed, your medical history. And then the staff is also going to not only review all that here in the surgery center, but they're also going to check all the needs for your procedure, like any special implants that need to be available, making sure the equipment is properly working, and make sure everything is doing, working on all cylinders. We don't want to have any problem and not be able to perform your procedure, and it's all checked well before you get there. When you get to the pre-op holding area, these simple things like the vital signs are taken to make sure everything is good. The nurses will place IVs. and you're going to ask, you know, pertinent questions like, what did you eat for breakfast? And the answer to that categorically is you should say, I didn't eat anything for breakfast, because in surgical, you need to be have no food by your mouth, you know, for the past at least 8 hours. The nurses, again, are going to check your current medical condition. Your doctors will ask, has anything changed? And they will make sure that you're still in a good candidate for doing surgery in the surgery center. Your surgeon will greet you. They will confirm that you are the person that you are with an identification of your wristband, and they will check to make a site marking, and they'll ask you, what are we doing today, and what side is it? And these are all safety checks. The physicians all know what they're going to do, and they all know who the people are, but it's all safety checks. Then you'll greet with the anesthesiologist, and the anesthesiologist will, again, another person will look at the medical history, the surgical plan, and the anesthetic plan, which has already been reviewed prior, but it'll happen again. It's all, again, safety checks to give you the best possible care that we can. If there's any questions, please just go ahead and send them off, and I can stop to answer them too about any of the things I mentioned. After that, you'll go back to the operating room after everything is squared away. You will then meet the staff. Some of the staff will actually come greet you in the pre-op holding area. The nurses will, the circulating nurse. And then when you come back to the OR, you're going to meet the scrub tech and people in the operating room that haven't met you so far. And they'll introduce themselves. And they're actually going to verify your identity again. Again, it's all about safety. You're going to have your vital signs continuously monitored. And then at some point, where your anesthesia is going to be induced, whether it is a block, whether it is going to be general anesthesia, or just kind of you fall asleep during surgery and you're not really asleep at all. It's just, you know, medication to make you rest. A timeout will occur. And in this case, your ID is checked another time on your wristband. The entire procedure is gone through with everybody in the room doing nothing but listening to the person reading the permit, the timeout sheet, and your consent. After that, everybody agrees with that and there's no concerns or questions. They verify that your antibiotics have been given. And then, again, the procedure is reviewed and making sure all of the implants and necessary things to proceed. And this is before anybody makes an incision, because they want to make sure everything is proper and okay. Then the procedure happens. And I'm going to show you some of the instruments now that are in the operating room. The first thing I want to show you is the camera that we put into the minimally invasive joints. This is one of the cameras, and this goes into the joint. This is a small, the size of the incision is the size of this little tube. That's how we do it, all through little poke holes. And then the camera goes in the middle of the tube, and so we can look around the joint. And when we turn the camera in certain ways, or turn how it looks, what happens is it changes the view, and we get different looks inside the knee. And I'm going to show you an illustration in a moment of how things look, a video of how it looks, and what we're doing in the actual procedure. Some of the instruments we use are things like this, when we have to grab a tissue, and I'm going to keep it close to me against my, you see it goes up, and that's the grab, and this goes through that small little hole, this instrument, okay? And sometimes we just have to make little bites of tissue, like when we're fixing a meniscus, we make little bite maneuvers. Other implants or other instruments that we have are things that grab tissue and pass sutures through it. And then what we do is we tie knots outside the joint, and we slide the knots in and then tighten them down in there, holding the tissues that we repair together. So it's all done minimally invasively. And we will show off that video. We could probably show off the shoulder video if you have right now, fixing a rotator cuff. If you can cue that up for us, Brooke. While she's queuing that up, here it is right now. So this is one of the, I particularly use Arthrex company's implants, and we're gonna hit play, please. So this shows the portal sites. You can see the plastic cannulas on either side, in the front, the back, and on the side there. Now, those are just in the skin, and there's no skin on this. This is the right shoulder. That's the rotator cuff right there that's being delineated. And you can see the hole just to the side of that. That's the upper arm bone, the humerus that's been delineated. And then the tear is the U-shaped hole that you can see there in the video. Now, the glenoid is where the ball sits and articulates. Now, here's where we grab the tissue, and see if it reduces back to its normal position, and we see it does. And then what's going to happen is you prepare the surface with a special instrument because you have to heal to bone. That's called a burr. We remove the instruments and we replace them to make sure we have a good view. And here we're making a hole for the anchors to go. And then we take the anchor, and you can see it in the little circle right there. We're going to then screw it into that area. And we gently screw it in. And then we remove the sutures. And then we have to now pass the sutures through the portal. We have to grab them. And then we're going to put them through a special suture passer that's going to go through the torn tissue. So when we tie a knot or when we put the other anchors in, we create something called a bridge. So there's the one suture being passed, and we pull it through. And we're again going to grab it and move the suture to a parking portal. We leave that suture in place there. Then we're going to put a second hole and a second suture and an anchor. And then after that occurs, we're going to grab both of the sutures out. And we're then going to give it a bit of a tug. We're going to pass it through another implant to go on the outside. And we're going to pull it down and then suture it back into place. And then we're going to put a second one in. So we have a good footprint. There's the anchor going in for the first one. We're going to take that out. We're then going to put a second anchor in. We're going to grab those two. And now you're seeing from the back. And we're going to put an additional suture in just to make sure that the rotator cuff has a good apposition to its normal position. And we're going to incorporate that. Now here is the next anchor. And you can see there's kind of like a crisscross pattern there, getting a full rotator cuff footprint repair. There's the repair after all of the portals are out. You can see a beautiful repair, and then it just takes time to heal. So that's what it looks like from an animation point of view. The other things that we do in the operating room is after we're done the procedure, we close the wounds and we put the dressings on. And then again, to review with the nurse everything that we did, we get the circulating nurse, and we again review all of the things that we did. One, to make sure that we follow what was on our permit and our consents. And two is to make sure that we did everything we said we were going to do, and there's a complete repair of the patient's injuries. After this, the patients are then brought over to the anesthesia recovery area, the PACU, and we then go ahead, and all of the PACU nurses are ready for the patient to be taken in. We check all the vitals. We make sure a report goes to that nurse so they know exactly what we did, and they know exactly what to check for and monitor. So it's all safety generated, and everything is done to have the patient's health and well-being first priority. After the patient recovers, in certain cases, they'll start walking around in the PACU area. Other people won't need to do it if there's less of a severe case, and those people, if they just had a less involved procedure, they'll just wake up and they'll be able to go home relatively quickly. All of the discharge recommendations and plans of the surgeon are then reviewed with the patient, and then we're sure that they know exactly what they need to do. The next day, the patients are called and checked upon, making sure they're all doing well. And some surgeons call their patients the night of surgery just to check on them. That's one of the things that I do. So we're at about almost 20 minutes in. Does anybody have any questions? So I have a question here that was presented to me. So the question is do we do mostly minimally invasive surgeries for knee meniscus repairs and meniscectomies, or do we ever open them? The answer is we typically do not ever open them. In days past, they were opened and they would do a full meniscectomy, but we've learned over a period of time that a full meniscus being removed would actually lead to earlier arthritis. And the earlier arthritis was averted and decreased when we went to just the partial meniscectomies, where the meniscus was only removed in part, just the torn part that was the pain generator. And so that's a change that has happened of late. The other aspect of the minimally invasive and I'll just touch upon the rotator cuffs. In the past, people used to do open procedures quite frequently, or mini opens. As the technologies have improved so vastly, most of them are done in an arthroscopic manner, meaning through the portals, and they're done quite successfully. In the past, I did used to consent patients for a possible open procedure, but I have not needed to do that with all of the incredible advancements, and so I don't even consent for open procedures for most of the repair work we do in the rotator cuffs. Are there any other questions? Okay. Well, I wanted to say thank you all for partaking in the Facebook Live presentation. I appreciate you watching, and we all at Premier are privileged to be able to take care of all the patients that we do in the region. Thank you.